Hello, I'm Rob Lott. I'm a deputy editor at Health Affairs, and I'm thrilled to welcome everyone here today for Health Affairs' latest Lunch and Learn. Our subject today is the future of health system transformation. More on that in just a moment, but as we get underway, I want to invite members of the audience to introduce themselves in the chat. We also encourage you to keep your cameras on during the Q&A portion of the program. This event will be run just like all of the Zoom meetings you have attended in the past. Our speakers will present for approximately 20-25 minutes using some PowerPoint slides. Guests can submit questions to them either by raising their virtual hand in the reactions tab at the bottom of the screen, by typing your question into the chat, or if either of those fail, by waving your hand into the camera. You don't have to wait until the Q&A period to type questions into the chat. Feel free to enter them anytime during the presentation. Slides will be shared with attendees in a timely manner via email after the event. Okay, so Leading to Health is a series of journalist-written articles published every month in the journal, describing the experience of leaders implementing patient-centered delivery reform in pursuit of a culture of health. Our goal for each article is to do two things. First, profile an example of health system transformation, and second, place the example in the context of public policy and other external factors affecting the success of the transformation. So if that sounds a little vague and broad to you, you are correct. It is. This was intentional. Part of what I'll talk about briefly here today is how over the course of this project, we've tried to figure out what all this actually means. So this project initially came out of conversations between our editor-in-chief, Alan Weil, and Emmy Ganos, a senior program officer at the Robert Wood Johnson Foundation, the generous funder of this ongoing project. Emmy Ganos is part of the team at the foundation that specifically focuses on, quote, transforming health and healthcare systems. And the idea that Alan and Emmy hatched was simply to tell the stories of what it means and what it takes to pursue a culture of health. I'm going to attempt to forward the slide here. There we go. So what does it mean and what does it take to pursue a culture of health? What does it mean to embrace team-based and whole person care, integrate disparate elements of the healthcare system, collaborate across sectors, look upstream, and engage patients where they are? So these were the guiding principles of our project. And to be honest, they're all phrases we've heard a million times before. We kind of have a sense what they mean, but again, still sort of vague. We saw that mystery, though, as a feature, not a bug for our project. And we did have some confidence that Health Affairs was in a good place from which to investigate this mystery. And that as an organization, we could help tell those stories in concrete, credible, and clear-eyed ways. These were the questions that deserved more than just a bunch of glowing reviews of systems doing amazing things, more than simple puff pieces. They deserved an independent lens to elevate and learn from the successes, but also while examining the obstacles that make transformation so challenging, and the disappointments and the frustrations that often stand in the way. So we started by identifying and inviting an advisory board and hosting a kickoff planning meeting. Our goals with this meeting were to figure out what exactly the articles should look like: length, style, subject matter, as well as to begin identifying specific systems to profile and setting up mechanisms to identify systems going forward. Ultimately, we came up with a series of key elements that each article should attempt to address, recognizing that no one article could realistically cover everything. Among those elements were how we got here, What are the root causes of the specific problems that the system being profiled is trying to address? The system's or leader's vision and underlying philosophy, and how it informs their progress toward transformation, how organizational leadership and culture advances a system's vision of transformation, or sometimes fails to. Concrete and specific examples of how system transformation has improved or aims to improve patient outcomes and experience. Stakeholders' roles, including physicians, nurses, community health workers, administrators, family caregivers, and how they intersect in the cause of system transformation, as well as the role of financial incentives and early results if applicable. And this is the big one as well, potential generalizable lessons learned. So put it all together, and we hope to provide through these articles accessible, actionable information and tools to help health system decision makers confront the work of system transformation. And so with all that in mind, we identified some specific tasks we wanted to put before the journalists writing these pieces. Our hope was to give them the guidance they needed to strike a balance among telling colorful and compelling stories from the ground level, providing specific details and concrete examples, asking hard questions about the pain points and potential obstacles to long-term transformation, presenting each case in a broader policy context, such as asking questions like, what are the implications of each story for local, state, and national health policymakers? And importantly, the patient voice, which is really more broadly the patient voice, but also the caregiver voice, the advocate voice, the community member voice, any non-institutional, non-professional voice. So we came away from this initial planning meeting feeling like finally we were getting somewhere and giving this project and these articles some definition. But we still had this nagging feeling that we didn't know exactly what these articles would look like in practice. Yet at this point, we figured we couldn't get any further just talking about them. We had to start developing them, taking all of these ideas and suggestions and turning them into articles. So here we are, fast forward 3.5 years. And today we have 34 articles in print and another half dozen or so in the pipeline. You can find all of these articles on our awesome landing page, which has articles curated by topic area, links to join a LinkedIn group and sign up for a monthly newsletter, all in the hopes of building a community using these articles and this project as a foundation where system leaders and stakeholders can connect and learn from one another. There's also a very cool map illustrating where these systems are located. A reminder that no single system or community has a monopoly on system innovation. It's happening all over the country, all over the world, and we've really sought out and tried to profile efforts that might otherwise be flying under the radar. So in the past, when I presented this program, I provided kind of a whirlwind tour of all the systems we've covered. I could do that when we had 6 pieces in our archives, maybe 13 or 20 systems that we profiled, but with 34, I think we'd be here all day. So instead, I just very briefly want to point to a few common themes that keep surfacing again and again through these articles, in the hopes that it maybe whets your appetite for more, and definitely encourage you to go back and check them out on our website along with many others. So one theme here, I've got 4. The first is centering primary care. And for example, we had reporter Bara Veda cover the Anne Arundel Medical Center and their work to establish a health enterprise zone in Annapolis with a particular focus on the system's new clinic based in the Morris Blum low-income senior housing apartments. Another article by Rebecca Gale reported from Wilmington, Delaware, the effects of Nemours health system efforts to address the social determinants of health while making a big move to value through their pediatric care network. And in May 2020, David Teller covered an LGBTQ focused primary care clinic in Cedar Falls, not Cedar Rapids, Cedar Falls, much smaller Cedar Falls, Iowa, which has really become a hub for this health system's work in this area with this population. Our next topic or common theme, behavioral health, or really efforts to reimagine behavioral health. In February and March of 2020, we had a two-parter from reporter Rob Waters, who first wrote about the successful efforts in Trieste, Italy, to deinstitutionalize their mental health system. And then he wrote about how Los Angeles County mental health officials visited Trieste a bunch of times to learn from their successes, and now they're trying to do something similar in LA. And finally, Michelle Cohen-Marill wrote about a program in Georgia referred to as forensic peer mentoring, one of the newest segments of a broad peer support system for people involved with the judicial system who have a diagnosed mental illness. Another common theme, looking upstream. It seems sort of obvious, but it's of course easier said than done. And we tried to profile some systems that are succeeding in this work. Reporter T.R. Goldman reported on the Pathways Community Hub in Toledo, Ohio, a unique model of care coordination. Brian Rinker examined work in Sacramento using their Medicaid funds to help their homeless population find housing as part of California's whole person care program. And T.R. Goldman also reported from Washington Hospital Center about a violence interruption program that has embedded social workers and community health workers within the trauma center there to reach victims of violence in an attempt to break the cycles of violence in the city. One last common theme, community engagement. T.R. Goldman wrote about an interprofessional group of healthcare students and faculty members from Virginia Commonwealth University who are helping local Richmond seniors solve health problems early. Jessica Bylander wrote about the Zuni Youth Enrichment Program at the Zuni Reservation in New Mexico, a program that aims to address chronic health challenges among youth using their own strengths while building the program specifically around Zuni culture and traditions. And lastly, I will start from the beginning. Our very first article in the series was at the University of Texas Austin Dell Medical School, where our correspondent Jessica Bylander described the work of standing up the brand new medical school and establishing its mission of serving the community. And so one of the leaders in that program who was integral to the work of getting that school started was our Dr. Minnie Kahlon, our guest today. Dr. Kahlon is a vice dean for the health ecosystem at the University of Texas, Austin, where she drives Dell Medical School's enterprise focus on innovation, specifically to improve health outside the clinic. Minnie is also the director of Factor Health, a real-life health provider network that tests and builds businesses that improve health outside the clinic. And we'll learn a little more about that today. Dr. Kahlon has a neuroscience background and brings a diverse experience to drive the transformation of our health system from healthcare IT and informatics, consumer software, networking startups, social impact NGOs. And we really couldn't think of a better guest to have here today to talk about the future of health system transformation. So with that, I will hand things over to Minnie.
Hi, can everybody hear me? Okay.
Yes, we can. Thank you.
Excellent. Excellent. All right. I am going to pull up my slides, but actually I'm going to try something here. So as Rob mentioned, we are here a brand new Center for Academic Medicine, now 7.5 years old. I came from San Francisco, actually have some of my old colleagues here, which is wonderful. And we came because we believe that academic medicine is a is essential to innovate in health and to help really push health systems to transform and improve in improving people's health. But we also felt that we came from UCSF. I came from UCSF, a wonderful place, and with a lot of actually some of the best work in the area we're going to talk about coming from UCSF. But there are some fundamental challenges for academic medical systems that exist today, which is that they fund themselves through margins made in the clinical enterprise to sustain research and education. And that's just the business model of the academic medical center. And we thought that, among the other things, starting a new Center for Academic Medicine could help us get to the heart of that conflict. In addition, we were really drawn by the fact that the community here in Austin voted to increase their taxes, yes, here in Texas, to help fund a new medical school. That comes with a lot, and you should read the article that Rob mentioned. You'll see sort of the messy world that we're in, and I say messy with great love, because to do good things means you have to get messy. And in both the sort of early successes as well as the challenges are well described in the article, including, we are a medical school that focused on really creating results for our community, in addition to producing innovations, research, and of course trainees and improving education. But I just wanted to say up front, in case anyone thought it's not all as simple and straightforward as that sounds. And it has been a complicated and fascinating path that we're still in the midst of. I was going to try to see if I could show you. I think it's too bright, because if you looked out here, oh, you can't see it, darn it. On the right, there is the old public hospital has been demolished because we have a brand new one behind us. So you see, sort of, we're in the heart of downtown Austin, and you see this rubble, and you see a shiny new building coming up on the right. So you sort of visually, I'm right sitting here in the midst of this transformation still. And I don't say shiny new building, meaning that is actually what's important for what we're doing. In fact, as you'll hear, part of my focus here has been to think about what health means outside the trappings of what we're used to in the clinical enterprise. So with that, let me try to bring up my slides. Okay, give me a second. I'm going to get this right. Okay, so I think that we should be good, and somebody will let me know if we're not. So
you're good to go.
Okay, excellent. Oh, that was me. Did it just disappear again?
Yes, it did.
That was me.
There we go. You're back on.
Okay, so right, so we're going to talk about transforming our healthcare system, and the answer in this talk, at least, is going to be, or the part of the puzzle we're going to focus on here is really looking outside of the healthcare system, and you'll see what that means in a second. And you can guess it's another way of saying, really focusing on the social drivers and the social determinants of health. Okay, no problem. Okay, this is, all right. So, I'm sorry, it'll take me a few minutes to get this going properly, but this is really the problem that we're trying to solve broadly. And this is a great slide from Dave Chase that I feel like not only summarizes what you all know about, which is on the left-hand side here, about what drives outcomes, a variety of factors, only a small amount of which is addressed through clinical care. But even more important, we spend a lot of money on healthcare, and it is disproportionately focused on things that are not aligned with where the problem's at. So this I use this, the story of the cop that is looking for in this case, it's a person who's looking for the key under the light, or the person that's looking for the key under the light, and the cop says, well, where did you lose it? And the person says, well, 2 blocks away. Well, why are you looking here? Well, that's where the light is. And to me, that's the most useful image as I think about, even as we address social determinants of health, the drivers of health that lie outside the clinical enterprise. Our approach still ties to the clinic and the clinical enterprise. And part of what we're trying to do here is to really disentangle ourselves, to anchor ourselves out in life, and hopefully get answers that are truly more integrated into people's lives. So this is just sorry, I'm having, there we go, much better. Okay, so this is just a reminder that that when we deal with the healthcare system, we're dealing with an entrenched system that has a lot of momentum and inertia of its own. And just as an example of what that means, if you think of this is the desktop operating system market share worldwide, just from the 2010, and it would look worse if you went, earlier on. And the dark blue line here is the market share that the Windows operating system has had. And overall, you can see they've had a really high market share, and that's pretty much sustained over decades. Nothing much has changed when you look at things at scale for the personal computer market and the operating systems that run those markets. Okay, so this is, gosh, I'm sorry, I'm having trouble forwarding these slides, but so this is instead smartphone sales, and this is looking at operating systems for smartphones, and this of course starts only in 2007. But the reason I brought this up, you can see, is that all of a sudden you have this new operating system, Android, that's really accelerated beyond the others. And part of the reason is it had a completely different platform to play with. And so my point in this is that if we really want to address health outside the clinic by being outside the clinic, it's going to be really hard to do that if we stick with the platform that we have, because the platform that we have, the clinical enterprise, has got a huge amount of inertia embedded within it. And so we take that frame as we ask, how can we improve health in the landscape of life? And I am going to try to improve my ability to keep moving things ahead here. I apologize. Okay. So I'm going to move right ahead from here. This is just makes the point that the healthcare system has huge expenditure. Okay, so what's the new platform that we can use to really design and implement something new? That's a question we asked. Well, one of the new platforms that's come about that has created huge amount of disruption and change and investment has been in digital health. And that's been driven primarily because that's where the money is. The money understands digital health, it goes to digital health. But I think, and this talk is not dedicated to that, we could have another one on it, but the results from digital health have been lackluster and in and of themselves are not going to change how we actually deliver health, especially to people that need it the most. So instead, our focus is to deliver health in the landscape of lives. And so where do you start? You don't start with tools. You don't start with fancy devices. I think eventually we get there, but you start with where people live and what's important to them. Family, food and eating and companionship, and the ability to do all of those things, time and resources. Those are the kinds of constraints. That's the landscape within which we hope we can actually improve people's health. And when we do that, then we can say that we're truly integrated into people's lives, not demanding that they come to the clinical enterprise, to the healthcare institution. So there are some great examples of this work. We are not the only ones doing it. I wanted to point out a few. Some of you might have seen the announcements of this great, very fascinating grant that just came out where researchers from Penn, it's a very interdisciplinary team, are going to work in neighborhoods in Philadelphia, where they're going to look at specific environmental and economic interventions, so healthscape or interventions in the landscape of lives, and look at the effects of those on health. Here's another one. Professor Hardiman is going to study the effect of police violence on the birth outcomes for Black infants. Very, very important problem, and one that she is now addressing by looking at where the problems lie to begin with. These are all very exciting projects, and I can't wait to see what we learn from them. This too is a very promising trend. I did this actually for our own community at Dell Med, where I wanted to understand whether Dr. Hardiman's study was such I was surprised it was funded by the NIH, frankly. And as I did a search for police and violence in the NIH reporter database. I found that, of course, in early years, there was nothing funded, but more recently, you can see the uptick in projects that are beginning to be funded, and that's very heartening. I just did a control here on environment and health just to try to understand, what the other hit rates could have been, and you can see that on the left. So lots of really exciting work, and that is the milieu within which the program Platform Health Factor Health that I'm going to talk about is situated. All right, so this is our particular part of that puzzle. It's a big puzzle, and so if you look at this schematic today, we have upstream determinants of health, structural drivers, racism, institutional investments that are warped right now that we could fix. We have midstream health that deals with chronic disease management, and then we have a lot of money that we spend on acute care downstream health. The opportunity is to expand our focus on upstream and structural determinants and drivers of health, but also to really improve how we manage chronic conditions in this sort of midstream space. And as a result of all of that, really reduce acute care and this downstream funding. And so our part of the puzzle in Factor Health, a lot of people are doing different things, is within this sort of midstream piece to really ask, can we deliver better ways to manage chronic conditions, to prevent chronic conditions, but in the cadence of people's lives, rather than, again, requiring them to come to the clinical enterprise. So specifically, we took on the challenge of saying, let's think about addressing individual and family risk factors. And family actually is a very interesting place that we build to by first starting with individual risk factors. We can talk about that in the Q&A. And we look at interventions that are less than a year in time period to implement, generally 6 months or less, so pretty short term. We look at ROI to match payer interests, which is less than 2 years. You'll see that we're really focused on making sure that what we design can actually be sustained. And we focus on the under and uninsured or otherwise where need feels the greatest. We do expect that those answers are relevant to all, but instead of trickle down, we think of, evaporate up. Okay, so this is just a reminder, this is sort of where we started, that actually you can make significant difference in people's lives, even with short-term interventions that are much more integrated into the cadence of their lives, so have much less burden for them, and therefore in many ways are already better for them. And so this is the Berkowitz paper on how meal delivery programs reduce the use of costly healthcare, and this was in the case of dual eligibles. And some of the results are here, and you could look at many of them, but they're just very striking. You can see the inpatient incidence rate ratio is 0.41 for those that receive medically tailored meals. Even the non-tailored meals did much better than those that didn't get meals. And this has got some coordination on the clinical end, but the primary area where this work happens is between the person who's delivering a meal and the person who's receiving it and eating it. And so this is one of the kinds of results that we anchor on. Now for us, where does that take us? So let's just take the medically tailored meals program, for example. We have within our portfolio of projects at Factor Health, shorter term interventions, one such program, diabetes management at home for homebound older adults. Now the Berkowitz paper I showed you focused on people with a range of conditions, but didn't look at hemoglobin A1C, they looked more at hospitalizations. This is an interventional program and trial where we will look at managing how we can better manage diabetes by meeting people in their homes with things that matter to them. And so in this case, and this is a representative of our factor health approach, we take a lot of things into consideration, all of which we believe are essential for us to deliver a strong program that benefits the person at the other end on their own terms, and that could potentially be funded in the long term. So we have a specific population. In Texas, we have not expanded Medicaid, but we have a Star Plus program that focuses on people that actually look very much like our provider partner, Meals on Wheels, their clientele. So these are homebound older adults with diabetes, in our case, with A1C levels above 8.0. We look at specific health measures that we speak to payers about, and they tell us what they're interested in. No surprises there, A1C levels, but also mental health. And then we have, programs that are designed with various components, and we think through the protocol of the programs with our partners. And this one includes medically tailored meals and social connection. I'll tell you a little bit more about that in a second. For each of our programs, one of the unique aspects of Factor Health is that we bring the payer in at the beginning, because we really do need to eventually see these programs paid for if they deliver value. We believe they will deliver value. If they deliver value, then why not have them paid for in the same way that a drug would be paid for, or an emergency department visit would be paid for. And so we have a unique arrangement, which we'll come to at the end. We call it an accountability agreement, where we work with, in this case, it was United and Amerigroup with the Medicaid MCOs that joined us in this, where we bring third-party funding, in this case, the Episcopal Health Foundation, and we work with payers to get them to sign an agreement that says, we are interested in this population, we're interested in this condition, we like the program you're implementing, and if you achieve results, and they help us define what those results are through this program, and you work with us on what the economics looks like, we will commit to scaling it in the future. And there's detail to that, which we can talk about. But one of our early milestones was to get the Medicaid MCOs, in this case, to sign, and they did. And so we have several such partnerships in place, and we don't launch a program without that agreement usually in place. And that creates a very different relationship with the payers from the start, and as you'll see, that makes a big difference. I'm going to need to shoot through these because I do want to save some time for questions. So let's just go through this quickly. I want to get to move on to some results. So this is just generalizes and tells you a little bit about all the pieces we look at with Factor Health for all of the programs we do. What's the evidence? What do we base this on? Do we believe it will work? A population, who are the best provider partners? They are usually community-based providers that we build strong relationships with, who themselves have the trust of the people that we serve. Sometimes we design programs ourselves, like the next one that I'll tell you about. And then, of course, we anchor on payer interest. So I do want to tell you about how we're moving, and some early results. Actually, the first programs that we ended up implementing came through chance. We were going to start a medically tailored meals program, and instead, COVID struck in March, just as we were going to start, and we had to stop delivering meals in the same way that they were doing before, because they were concerned about those that they were delivering to. And we realized that actually, for the very people that we were going to serve with our program, there were other issues that were going to become even more relevant, social isolation and loneliness. And so we designed a program very rapidly, and we began designing in April. We began our programming in June. We started outside the clinic, as is our approach. And we begin with the minimum license necessary to achieve results. For us, it was lay people, it was young lay people, 17 to 23-year-olds. We were forced to innovate with very little. So we couldn't even do video conferencing, because that meant we would have to go into people's homes to help them set up video conferencing. So we used the good old telephone, which is still a powerful tool. And we set up a layperson delivered program, a phone call program that was designed using everything that we were emphasizing. So the program was defined by the participant. The participants decided what they wanted to talk about, when they wanted to be called, how often they wanted to be connected. Our callers were lay people. They got 2 hours of training, one that was training on the North Star and kind of what we were guiding them towards, and another that was in logistics that was 17 to 23-year-olds. And each had a panel, just like as a physician, you have a panel, and it actually helps you because you can see all the different patients, and sometimes some are harder, some are easier, and that really helped our callers as well. And it was a 4-week program, very short. We started with 5 calls 5 days a week, but then we asked people at the end of that, now that you've seen this, is it good for you? Do you want more? Do you want less? Half said they wanted to reduce the frequency, but they stuck with the program, and half wanted the same number of calls. And the main feature of this program was really people calling because they were interested in the person at the other end of the phone. And they told the other person, what do you want to talk about? And with a few, sort of conversational tips and tricks, everyone had something they wanted to talk about. And they shared what was on their minds, whatever it was. And if they didn't want to talk, they said, yeah, no, I'm good. And that was fine. And so for this brief moment of time, we believe one of the things that's really important is these folks set the rules. They set the agenda. This is what they wanted to do. And they set the tone of things. And we believe that's a big part of the puzzle for this and other programs. We embedded a randomized controlled trial in this. I just want to share some of the results. I'll move past this, but this is really the people that we were serving. Majority were women. It was about 40% were African-American, about 21% were Hispanic or Latinx, and they were all had a range of chronic conditions. You can see that down here, and some, about half were living alone, but half weren't. But the majority were single, divorced, or widowed. So this is just results on our loneliness scale, which is where we started. And these were really a score of 6+ on this scale means you're quite lonely, and this is the average. So the scale goes from 3 to 9, and an 8 is very, very lonely. So an average of 6+ was quite lonely. Blue was intervention, orange is control, and you can see that we had substantial effect in 4 weeks. And in these results here, so we also, as secondary measures, we looked at depression and anxiety, which honestly, we did not expect to see the results that we saw. So you can see the first thing is for these scales, the PHQ and GAD, averages of 6 are not very depressed and not very anxious. And I would say that really accentuates the degree of change that we saw, because it's usually easier to see change when you have higher scores. But we found striking, meaningful, and statistically significant results on depression and on anxiety at the end of 4 weeks. And so this was really compelling results, but even more are the quotes. And this tells you the kind of impact we can make in people's lives if we focus on them. You would be surprised how helpful the phone call is. Just talking to you has made me so happy and so motivated. I want to go to make dinner and dust my apartment. Wow. I don't even know who you are. You're a complete stranger, and I'm talking to you like we are related. I have so many such quotes, and I just got goosebumps, and I get goosebumps every time I read one of those. And I would say, if there's one thing I want you to take away from this talk, is that if you really center on what people need, sometimes the needs are simple, and it does require, though, us letting them set the rules of the game. And that is what we try to do systematically through Factor Health. To wrap this up, I wanted to share, we talked about the medically tailored meals program that we're launching, and I wanted to share where we're going with the results of the loneliness program that I just shared with you, just to show how that ties to our goals of really sustaining scalable programs. So we're definitely supporting a range of groups that have come out and actually reached out to us. They have their own caller programs. We have tips and tricks and tools, and we help them understand what we did so we can maximize the chance that they get results. Plus, I love that these groups can use the paper to demonstrate to others that their work has meaning and is likely generating results. But because we believe this is a huge problem, mental health in general, we're also looking at more formal ways for the health system to really take note that such programs that are delivered entirely outside the clinical enterprise really do deliver results. And so we're focused in 2 areas to make sure we can increase value. One is we're pairing this with chronic disease self-management. In this case, for F2HC patients, that program is starting in a couple of weeks. We're looking at diabetes people who have diabetes, and adding an empathy-first approach to really helping maximize the impact of traditional diabetes self-management approaches. And then the second is really now starting to look to a similar Meals on Wheels populations, but really starting to screen for those with depression and anxiety to really see how much of an effect we can get and improvement in their lives. This gives you a sense of the scale, so hopefully you'll have questions about all of this. We're currently in many places in Texas. We're also doing some national work with Fair Food Network on the role of fruits and vegetable subsidies, and where we can look at some national policy work. We work locally on policy at HHSC at our Texas level, because sometimes fairs want to pay, but actually cannot because of policies. We have to work there as well. And then this tells you some of the areas, diabetes and depression and kidney disease as well, where we're working in for these shorter term programs. I am going to race through this because I want to just share a little bit about our payer strategy. You may have questions about that. We work very closely with these payer partners that become sponsors of these programs. We invest a lot of time with them. We listen to what they need, and we try to both respond to their needs. But every time we do that, we bring something new to the table. So hopefully we are helping expose them to other ways of thinking about delivering programs. We enter without asking for money, although we are now in the process of getting a first sort of contract because we've shown some results. And this, we were lucky because we got a great funder, the Episcopal Health Foundation, who's really focused on health, not just healthcare, who has supported us with flexible funding so that we have been able to de-risk these for payers in the early days. We have a portfolio strategy. We have riskier things, we have less risky things, and that allows us to not only do some safer work, but to do some more interesting work that we think is potential. It's very relationship dependent. It's like negotiating in any business. That's really where the action is. We provide value wherever we are, however we are, because we know we need to keep people at the table. We understand their interests. We share our networks and our learning freely with everybody, but including the payers. And we have to get better at delivering programs and to focus on producing really high quality programs that maximize the chance that we get results. And we anchor on something that everyone can agree on. What works, what doesn't work, by how much, how long. And we're really honest when we look at the literature and the field, and we don't pretend like everything works, because everything doesn't work. And we have an opportunity-driven approach. So with that, I think for now, I will close with that, because I hope we have a few minutes left for some questions from the crowd. And I apologize for the earlier hiccups with the slides. I know it was a slow start.
Great. Minnie, thank you so much for that fascinating presentation. And I appreciate your valiant effort to cover a tremendous amount of territory in such a short time. I'm sure we could spend much longer really digging into the details. I want to encourage listeners to go ahead, put any questions you might have either in the chat or use the reactions tab to raise your hand, and we'll call on you. And I'll maybe get things started. Minnie, you sort of alluded to this in the slide when you made reference to sort of starting with a focus on individual factors and then kind of looking at it as a sort of continuum toward kind of broader family and community factors. And I wonder if maybe you could say a little more about that, maybe in the context of some of the programs you described, whether it's the meal program or the loneliness focused program. And then I guess the follow-up question would be, if you're going from individual to family and community, how does sort of the broader societal factors fit with that broader process that you're taking?
Yeah. So you know, the biggest thing, the most important part I said was there's a huge problem to be solved, and this is the part that we focus on. And what's important about that is that all of that actually has to change. So let's say tomorrow, for example, a wholesale, we change the way we invest in health. Wow, that would be fabulous. What a thought, right? And we invested in early childhood education, and we invested in a living wage for everyone, better than a living wage for everyone. Why not, right? And we invested in just make delicious food for everyone available everywhere. I believe actually that delicious food is even more important than food, right? Happiness is a right.
Sign me up.
Yes. So imagine that we did that. Still within that, we would want to know where and how to emphasize things. And so I believe that the approach that we're taking is going to be useful even when we conquer the biggest problems. Having said that, today some of the approaches we're taking are even more useful, unfortunately, because we are not investing at the right level, at the structural and societal level. So the example I'll give you, this is sort of like if you're thinking about work at the societal and structural levels, and then work at the individual levels, they all come together. And our approach to the next levels beyond individual comes from individual up, as opposed to societal down, which is just a different way of coming to the problem. So I would say food actually is going to be one of the biggest areas where you have to have family involved. And so we get in the door with payers because we can talk their language about individual risk factors and how can we get something that's effective for the problems they're trying to solve. But once we've done that, we have two programs that we're looking at. One is a school-based sort of whole family healthy food initiative in Houston. And there we are going to need multiple pairs at the table because we want to support whole family health through food that's delivered leveraging schools as community sites. So there we're looking at models where we would, any one Medicaid MCO will not pay for a school-based initiative because it's not all of their clients. And so we're looking at partnering with folks that could be a third party that helps to defray some costs while we create a multi-stakeholder method of potentially paying. But we're able to introduce that conversation because the MCOs are working with us on other things. And so they're like, all right, you seem to get us, we'll sit at this more complicated table. Another is kidney disease. Again, this is a project in Houston. And for kidney disease, if you're going to use fruits and vegetables, which is what we're doing, we're working with people like Don Wesson, who in Texas has really done some of the seminal science on how you can change the acid load with fruits and vegetables. If anything was food as medicine, that is. Yet, even there, it's so food as medicine and so technocratic relative to others, but you cannot change someone's style of eating without actually supporting the whole family. It's just not going to happen. And for kidney disease, it's not just a small change. You have to have several cups a day improvement in fruits and vegetable intake. And that is not going to happen without your family, without your neighbors, without people that you trust. And so we're looking right now at ways in which we can now build up from that individual to how do we support that larger unit. And for us, then how do we get the payers to generate, how do we generate enough value that we can get the right payers and the right organization of them to actually support that in the long term.
Great, thank you. I'm going to dive right into some of the questions we've got in the chat here. Could you speak about how you're evaluating physicians and providers on productivity, using the air quotes here? How have you gone beyond RVUs to measure whole person care?
So that's not a focus of my talk and not my particular area at Dell Med, if you're talking about Dell Med, but yes, we are moving beyond that, and we have some more traditional sort of clinical value-based payment contracting that we're putting together, and it's tied to our clinical provider reimbursement. But let's look at it on the side of the world we're imagining, which is that providers are the Meals on Wheels volunteers, or the people who are serving food out of the school, or grocery store staff, or all of these folks that become really critical as you think about delivering health and life. So there we are focused, and this is actually so interesting because I'm glad you mentioned the RGB thing. So even in our world, when we think about measuring both our delivery capability, but also how do you make sure that people are doing what they're supposed to be doing? Everybody, sort of our first default is like, oh, have they walked 3 times? Have we delivered food 5 times? And so in both those cases where the providers have you delivered food 5 times, we're trying to change the conversation to say, was the impact received? In the phone call program, instead of saying, you can believe that my Nazan, who's our statistician partner, she's fabulous, when we said, oh, we're not standardizing the number of phone calls. because we're going to let the people who are receiving it decide. She was like, whoa, and then she embraced it. Eventually, she's marvelous because she loves this sort of real life work. The dose there wasn't the number of calls. The dose was the amount of control that a person had. So I know this is a roundabout way to answer the RGB question, but all this to say that measurement and consistency and discipline in this social world that we're in is very important. But it's again there, just like the RGB thing, where it's not about the tactics, like how many of this did you do? It's rather how much was received. Did you feel like you had the impact? Do you feel like you have control? Much harder to measure, but those we believe are the more important levers to make sure you're on track and delivering high quality programming.
So on the topic of measurement, we have a follow-up question. What tool did you use to measure loneliness?
We used the UCLA 3, it's a 3-item. We also use we used 2 because loneliness is important, and we're trying to explore the space, a brief de Jong scale as well. Now, both of them we saw effects on, but actually interesting, we look at the paper, the de Jong effects were not as striking as UCLA, but that's for the aficionados on loneliness. More interesting, sorry, let me just say, more interesting. We did loneliness, which is the affect. I feel alone, and versions thereof. I feel like I lack companionship. And we also use the Lubin social network scale, which is a more objective measure of how many people you have, how many friends, and how many family members in your network. That did not change, which is correct because you had only one extra person calling folks. While loneliness, the affect changed so much. And I'm just going to leave that with you guys again as we think about what really matters to people in their lives.
That's great. So that has me thinking about your background as a neuroscientist. How did you apply that sort of foundation to this work, which you might argue is one step removed from the kind of purely, biomedical work that you may have done in the past?
Yeah. Well, I'm a systems and behavioral neuroscientist. So in many ways, this is a great fit to my background. But I will just leave you this because I know that we're also running out of time. I have to say, and this is for everyone who sort of followed their heart in a random walk rather than in a prescribed path, my background is highly random. And I think for most people, myself included at some points, it felt confused if someone forced me to make a narrative out of it. But just think about where we are with factor health today. It all is unbelievably important. My interest in behavioral neuroscience and my work in systems and behavioral neuroscience is absolutely essential to what we're doing. And the systems neuroscience part, it makes it natural for me to do systems analysis. At UCSF, before I came to Dell Med here, we were really looking at, I was working at the CTSI, the Clinical and Translational Science Institute, really looking at how to improve health systems so that our innovation actually makes impact. In addition, I've worked in the tech industry, startup tech industry, novel kinds of tech solutions, disruptive work there. And then, there's a bunch of other things. My point is, someone could say that none of that makes sense. And now think about disrupting health systems by anchoring outside the clinic and asking, how do you use one's knowledge about the health system, but to come at it from outside? And it all makes sense. So as a thought, if anyone out there feels like the steps they've taken doesn't make sense to someone outside, just wait. It will all come together.
Wonderful. Well, that's maybe a good tease. We should organize a career advice session with you next week. That's, I think, a wonderful point on which to wrap things up. Minnie, thank you so much for the work that you're doing and for taking the time to share a little bit of it with us here today. To our listeners, if you like this Lunch and Learn, I encourage you to visit healthaffairs.org to sign up for other upcoming events and join our email list to hear about them as soon as they're announced. I also encourage folks to listen to our podcasts, A Health Odyssey, with our editor-in-chief, Alan Weil, interviewing the leading researchers in health policy today, and Health Affairs This Week, where our trusted editors, sometimes with the help from special guests and thought leaders, discuss this week's most pressing health policy news. A few other items: on Thursday, December 9th, At 1 p.m. Eastern, Health Affairs is holding the next installment of its Journal Club, focused on a forthcoming paper by Kevin Nguyen of Brown University and colleagues. The paper is, despite national declines in kidney failure incidence, disparities widen between low and high poverty counties. We are also adding new events every day, so stay tuned. Again, thank you to everyone who joined us here today. Event sponsorship opportunities are available. For more information, check out healthaffairs.org. Thanks again to everyone, and please stay tuned for future events. We appreciate you taking the time to join us today. Take care.